First thing we'll be doing is assessing the upper cervical range of motion, active range of motion of our patient. To go into flexion, we're going to instruct our patient to tuck the chin in, and to go into extension, you're going to want your patient to do some forward head posture and then to lift their chin up towards the ceiling. When using a goni, use the auditory meatus as the fulcrum and the nose or the parallel to the nose as the distal arm. The upper cervical flexion rotation test is a test to assess for hypo or hypermobility in the upper cervical spine. From the supine position, maximally and passively flex the patient's cervical spine and then add rotation to each direction. Reproduction of the patient's pain or asymmetry greater than 10 degrees on each side would it be a positive test for this. To find TMJ mouth opening range of motion, have the patient maximally open their mouth. From here, use a small ruler to measure the distance between the bottom of the top row of teeth and the top of the bottom row of teeth. Normal range of motion here is anywhere between 40 to 45 millimeters for male and 45 to 50 millimeters for females. If during mouth opening you notice the mouth take a C-shaped path, this is called a deviation. Deviation is a sign of internal derangement or capsular pattern. If the mouth opening path deviates from the center but returns to the middle, this is a deflection. Deflection is a sign of muscle imbalance or lack of motor control. A few more points worth noting is that if an internal derangement is suspected, the jaw will deflect towards the less mobile side. An early deviation suggests hypomobility, while a late deviation is more indicative of a hypermobility. Next, we will be assessing our patient's lateral excursion at the TMJ joint. Usually using the middle of the top row of teeth as your point of reference, measure in millimeters how far the bottom jaw is able to laterally deviate from the center. Be sure to assess the quality of the movement for any clicking or popping before taking a measurement. Lateral excursion should be about 1/4 of the mouth opening range of motion. So for males, around 10 millimeters, and for females, around 11 to 12. Next, we will assess the strength of the neck flexors and extensors isometrically. With the patient sitting, apply a force directly backwards with your hand to assess the flexors, and then reverse your hand position, pushing forward on the head to test the extensor muscles. Assess the patient's side bending by stabilizing at the opposite shoulder while applying a force to the side of the head. Reverse the hand positions to test the other side. Assess rotation isometric strength by placing your hands on either side of the head and creating a rotational torque on the neck. Switch hands positions to test both sides. Next, we will be assessing the myotomes of the patient. Be sure when assessing myotomes to hold each position for about 5 to 6 seconds in an attempt to see if the nerve root fatigues. The C1 nerve root is assessing the patient's neck flexors. So similarly to how the isometrics were done, apply a flexion force on the front of the patient's forehead. The C2 myotome is tested by assessing the rotational strength of the neck muscles. Do this similarly to how we did the isometric strength testing with both hands on either side of the patient's head. Test C3 by assessing the patient's side bending or lateral flexion neck muscles. The hand positions are the same as when isometrically testing the cervical neck muscles. To assess C4, have the patient shrug and then provide a downward force on their shoulders. The patient should hold this position for 5 seconds. To test the C5 myotome, we're going to have our patient abduct her shoulders to 90 degrees and then push down on her shoulders, resisting shoulder abduction. C5 can also be tested by resisting the patient's external rotation. To test C5 or to test C6, we're going to manual muscle test the biceps brachii muscle. So we're going to have our patient in some flexion and then push down on their arm while they resist you. C6 can also be tested by manual muscle testing, wrist extension. So having your patient extend their wrist while you pull their wrist into flexion, and they will resist you. C6 can also be tested by resisting shoulder internal rotation. The two ways we can test the C7 myotome is through tricep manual muscle testing, the tricep muscles here, as shown above. You can also manual muscle test the wrist flexors. So similar to how we tested the wrist extensors, we'll have our patient flex the wrists while you pull them into extension, and they'll try to hold against your resistance. To test C8, we're going to have the patient extend their thumb, and then you're going to push down on their thumb, and they're going to try to hold that thumb extended position like shown above. After we do that, we're going to test the final myotome, which is T1. We're going to test the hand intrinsic muscles here, so having your patient adduct their fingers against your fingers just to test if their hand intrinsics are working. Any weakness that you find in this myotome testing will be indicative of a nerve lesion at that corresponding myotome. Next, we have the craniocervical flexion test. This is a test for cervical muscle strength. Place the cuff underneath the patient's neck and inflate it to 20 millimeters of mercury. You then want the patient to perform a chin tuck until the cuff reads 26 millimeters and have the patient hold this position for at least 10 seconds without any substitutions. If the patient is unable to do this, that'll indicate a positive craniocervical flexion test. Next, we have the deep flexor endurance test. Go ahead and flex your patient's upper cervical spine so that their chin is in a tucked position, and lift their head slightly off the plinth, and then ask them to hold this position for 10 seconds. If they are unable to, that is a positive deep neck flexor endurance test and is a sign of weakness in the deep neck flexors. First test for muscle length we'll be performing here is the stretch for the levator scapula. Go ahead and have the patient in some side bending and ipsilateral rotation of the head while depressing the scapula. Any tightness or limited range of motion or pain here will be indicative of a tightness or problem with the levator scapula. So next is the upper trap. For the upper trap, you're going to want to side bend the head away from the trap that you were testing, and then turn the head towards the side you're testing. You also want to depress the scapula on the ipsilateral side, and any pain or stiffness here will be a positive sign that there is a upper trap dysfunction. To test for sternocleidomastoid muscle length, you're going to want the patient's cervical spine in some extension. You want to side bend away from the side you're testing and rotate the head towards. Depressing or pushing down on the scapula may also help to increase the stretch on the sternocleidomastoid. If the patient was tight or if there was some pain with this stretch, that would indicate some tightness or dysfunction of the sternocleidomastoid and mastoid muscle. We can isolate the scalene muscles by instructing the patient to perform a self-stretch at different angles. The first is the middle scalene, which we can isolate by side bending the head away from the side being tested and applying some overpressure with the patient's arm. We'll tell the patient to perform this on both sides, assessing for any pain or discomfort. To assess for the posterior scalene, we'll instruct our patient to do a similar movement, only rotating their head away from the side being tested. This will help to isolate the posterior scalene, and we will once again perform this on both sides, assessing for any pain or discomfort. Finally, to isolate the anterior scalene, we're going to instruct the patient to once again side bend away from the side being tested, only this time we're going to have the patient rotate their head towards the side that is being tested. We also want to instruct the patient to either place their arm straight to their side or behind their back. Once again, you're going to have them apply the overpressure with their arm and assess for any discomfort or pain with these movements. In order to perform the cervical distraction test, there must be symptoms of radiculopathy at rest. If the patient's supine, a positive distraction test would indicate relieved symptoms when distracting the cervical spine by pulling on the occiput of the skull. When performing the cervical distraction test, you can further isolate movement to just the AA joint by stabilizing at C2 while distracting on the occiput. Next up is the anterior shear test. This is a test for upper cervical ligamentous stability. Place the lateral aspect of your index fingers along C1 and lift up superiorly. A positive test would be indicated by either a clunk or any of your upper cervical ligamentous instability signs such as double vision, nystagmus, or numbness around the mouth. Next, we'll be doing the transverse shear test. This is another upper cervical ligamentous stability test, and what you want to do is stabilize at C2 using the lateral aspect of your hand, and then create a relative transverse glide at C1 using your other hand. Positives for this test would be your upper cervical ligamentous signs such as nystagmus, dizziness, numbness or paresthesia, double vision as well. Moving on, we're doing the brachial plexus compression test. Perform this test by applying a firm compression to the brachial plexus using either your thumb or your fingers. A positive finding for this test would be if any pain radiates down into the patient's shoulder or upper extremity. Next is the cervical distraction test. From here, you just want to place your hands under the patient's occiput and lift straight up to the ceiling. A positive finding for this test will be if when the head is lifted or distracted, the patient's complaints of pain are relieved. Next test we'll be doing is the Sperling's compression test. Perform this test by having the patient flex the head to the uninvolved side first, and then pressing straight down on the top of the head, and then repeating the test on the involved side, looking for any complaints of the patient's pain. This test can also be performed in 3 phases. The first phase would be to compress the patient's head with the patient just in a neutral position. If phase 1 doesn't reproduce the patient's symptoms, you can move on to phase 2, which involves placing the patient in some cervical spine extension. Repeat the tests and once again assess for the patient's complaints of pain. If the patient's pain is still not being reproduced, move on to phase 3, which would include pushing the patient's head into some extension, side bending, and rotation. Make sure to test the uninvolved first and then move on to the involved side. The next test we'll be doing is the Jackson's compression test. This test is similar to the Sparling's test and involves the patient rotating their head to the uninvolved side first and then compressing down on their head. Repeat the test on the involved side by having the patient rotate their head to the involved side and repeat the test. If this reproduces the patient's complaints of pain, then this will be a positive Jackson's compression test. The shoulder abduction relief test is another test for neurologic dysfunction in the cervical spine. The test is performed just by asking the patient to rest their hand or arm on the top of their head. If doing this action relieves the patient's symptoms of pain going down their arm, that'll be a positive shoulder abduction relief test. Moving on to the upper limb neurodynamic test. These are tests for neurological symptoms that involve movement of the nerve and assess the sensitivity of the nerve roots and peripheral nerves to tension. The first nerve we'll be looking at is the median nerve. Start by placing the patient's arm in about 110 degrees of abduction and then to make sure to depress the shoulder. You then want to supinate the forearm, externally rotate the shoulder, and extend the wrist. From this position, begin to slowly extend the elbow, as extending the elbow creates the largest tension on the median nerve. If the patient still hasn't felt any symptoms or tightness, tell them to contralaterally side flex their head. A positive for this test would be reproduction of the patient's symptoms. To test the radial nerve, you're going to want to have the patient start in about 10 degrees of abduction and then go ahead and depress the scapula like we did for the previous test. From here, pronate the forearm, internally rotate the shoulder, and flex and alternately deviate the wrist. Slowly begin to work in that elbow extension, because as we stated before, elbow extension creates the biggest pull on the nerve. Add that contralateral neck flexion, and if any of this reproduces the patient's symptoms, that'll be a positive test. The last neurodynamic tension test we'll be doing is for the ulnar nerve. Start by depressing the shoulder like in the other tests, and this test can be done anywhere between 10 to 90 degrees of shoulder abduction. From here, externally rotate the arm, supinate the forearm, extend the wrist, and radial deviate the wrist as well. From this position, you want to flex the elbow, bringing the patient's hand to their ear, and then if this is reproducing the patient's symptoms, that'll be a positive ulnar nerve test. The Lemaitre signs test begins with the patient in a long sit position on a plantar table. Begin by flexing the patient's cervical spine. You then at the hip want to flex the hip while keeping the knee straight, and if this motion reproduces any sharp or electric-like pain, that'll indicate a positive Lemaitre sign. The first test we'll be doing for vascular clearing is the Haughton's test. Instruct your patient to flex their arms to about 90 degrees and close their eyes. Have them hold this position for about 10 to 30 seconds, and if you see one of their arms fall, that'll be a non-vascular sign. After this, you then want to repeat the test, only you want to have the patient's neck extended, side bending, and rotated, as well as having their eyes closed and their arms flexed to 90 degrees. If adding this extension, side bending, and rotation causes one of the arms to fall, that'll be a positive Haughton's test and an indication of vertebral artery dysfunction. Next test for vertebral artery clearing is the vertebral artery quadrant test. This can either be done in supine or in sitting. You want to extend, side bend, and rotate the patient's head to one side, holding this position for at least 10 to 30 seconds. You want to instruct the patient to keep their eyes open so that you can assess for any nystagmus. Nystagmus here would be a positive sign of vertebral artery quadrant test. The next skill we'll be performing is the assessment of the first rib mobility. While the patient is supine, palpate for the first rib. From this position, you want the patient to take deep breaths in and out while you assess the motion at the first rib. You can also have the patient side bend in either direction while assessing the mobility of the contralateral rib. With both of these motions, you just want to assess the patient for asymmetry between the two ribs, or if doing these reproduce the patient's complaints or symptoms. The Adson's vascular test is a test for thoracic outlet syndrome. With the patient in sitting, palpate for the pulse while the patient extends and rotates their head towards one side while you extend and externally rotate their upper extremity. Also have the patient hold their breath. This will be a positive sign if the pulse is diminished or occluded in the testing position while the patient is holding their breath. The costoclavicular test is done similarly to the Adson's, only you want the patient to retract and depress their shoulders while protruding the chest right in an upright posture and hold this position for about 60 seconds. While the patient is doing this, you're palpating for the radial pulse, and if it is diminished or occluded during this motion, that'll be a positive costoclavicular test. The Roux test is done by telling your patient to make a field goal post motion with their upper extremities. You then want to instruct the patient to perform slow opening and closing of their hands for up to 3 minutes. If the patient is unable to do this for 3 minutes, receives ischemic pain or significant heaviness or weakness in the upper extremities, that will be a positive Roux test. To perform the Wright's test, tell the patient to fully abduct their arm while you palpate for their radial pulse. Have the patient hold this position for 1 to 2 minutes and assess for any diminished pulse, paresthesia, or the patient's complaints. Any of these will indicate a positive Wright's test. The last test for thoracic outlet syndrome is the shoulder girdle passive elevation test. This test can only be done if the patient's symptoms are present at rest. Have the patient give themselves a slight hug while you passively elevate their shoulders and hold this position for up to 30 seconds. This test is positive if there is neurologic relief, that means changing from numbness to paresthesia or tingling, or if there is vascular relief, if the pulse is stronger, or increased hand temperature or improved colors of tissues. The first reflex associated with the cervical spine is the brachioradialis test. This is a test associated with the C5-C6 nerve root. Palpate for the brachioradialis tendon, then using your reflex hammer, strike your thumb over the tendon while the patient is fully relaxed. An absent or diminished reflex can be a sign of a nerve root lesion or impingement. The next reflex will be the biceps reflex, which is associated with the C6 nerve root. Palpate for the biceps tendon and place your thumb firm over the tendon. Strike the base of your thumb with the reflex hammer and assess the reflex that presents. Next, I will be looking at the patient's C7 nerve root, which is assessed through the triceps reflex. Lift the patient's arm in this hanging position so that the triceps tendon is exposed, and strike the triceps tendon with the reflex hammer. Once again, assess the strength of the reflex. To assess the jaw jerk reflex, have the jaws half open and place your finger on the mandible and then tap the finger gently with the reflex hammer. A slight closure of the jaw is normal, while a brisk and complete closure of the jaw is a sign of an upper motor neuron lesion. The masseter is one of the powerful muscles of mastication. It originates from the zygomatic arch and inserts along the angle or the lateral surface of the mandibular ramus. To palpate this muscle, have the patient bite down while you palpate around the surface of the lateral mandible. The masseter should protrude out, and you should palpate for any asymmetries or pain. The temporalis is another muscle of mastication that spans most of the temporal fossa superior to the zygomatic arch. Palpate just superior to the zygomatic arch and have the patient bite down again, and you should feel the muscle protrude into your fingertips. Again, assess for any asymmetry or dysfunction. Next, we'll be looking at how to palpate the medial and lateral pterygoid muscles. Both of these muscles must be palpated intraorally and preferably with the patient in supine. The medial pterygoid can be palpated on the medial portion of the mandible, near where the angle would be. Have the patient deviate their jaw towards the muscle being palpated in order to contract this muscle. The lateral pterygoid can be felt on the lateral aspect of the maxilla and can be contracted if you instruct the patient to deviate their jaw away from the side you are palpating. It is important to assess these muscles for any asymmetry or pain. Okay, so I'm going to be showing Michaela how to achieve the resting position of the tongue. First, I'm going to have her make a clucking noise like this. And now I want you to go like you're about to make that clucking sound, except don't make the clucking sound, so stop right before. And now that she's in that position, I'm going to instruct her that with her tongue firm against the roof of her mouth and with just a little bit of free range space between the top and the bottom rows of her teeth, she will be achieving the resting position of the tongue.